Yes, yes, madam.
Good evening, sir.
Good evening, all. This is Chandramogan, physiotherapist from Sri Samraj Physiotherapy Center, Sri Samraj Health Services Private Limited, Dindivanam, and Exercise Testing and Prescription, EXRX India. A warm welcome to all the participants for today's webinar on the topic of a systematic review of clinical trials and evidence synthesis, which will be presented by Dr. Ashokan Arumugam, MPT, PhD in Physiotherapy, Assistant Professor, Department of Physiotherapy, College of Health Sciences, University of Sharjah, United Arab Emirates. I would like to take opportunity to thank Dr. Badri Narayanan, cardiologist, who is a friend for myself and also a brother of our resource person, Dr. Ashokan Arumugam. With his suggestion, only we have reached to Dr. Ashokan Arumugam. So I am thankful to Dr. Badri Narayanan. Now I thank EXRX India team members, Dr. Upesh and Professor Tuna. And I welcome Dr. Ashok Arumugam and request him to commence the session. Please, sir, Dr. Ashokan Arumugam. Unmute, sir. Unmute and start, sir. Yes, sir. Now, please.
First of all, I would like to thank Dr. Chandramohan and team and Dr. Badri for suggesting me for this webinar. I appreciate this. And today's webinar is going to be a systematic review of clinical trials and evidence synthesis. It is just going to be an overview based on my research and learning experience. I hope it will be useful to you guys today. Thanks. Okay. I'll share my screen. I'm going to keep the video off now, but again, I'll open it at the end. Okay.
Yeah, no problem. Kind request to the participants, please do not use phone name. We will remove you. If you have a phone name like Vivo, we will remove you. Sorry for the inconvenience. Kindly put your name in screen. Unmute, sir. Ashokan, sir.
Is my screen visible? Okay.
Yes, sir.
Okay, today I'm going to present an overview of how to perform a systematic review of clinical trials and do evidence synthesis for it. Okay. Okay, the aim of a literature review is to objectively report the current knowledge on a topic based on previously published and unpublished research. First, I'll give an overview of main types of reviews that could be performed. Followed by that, I'll talk in detail about systematic reviews. The three main types of reviews are narrative reviews, systematic reviews, and scoping reviews. The types of narrative reviews include narrative overviews, editorials, commentaries. Narrative overviews are a comprehensive narrative synthesis of previously published information. Typically, they summarize and or critically apprise the contents of each study that is included. Most of the time, the critical appraisal part of the contents of each study will not be included. It usually typically summarizes the findings in the literature. I tried to do a narrative review in 2016 along with my colleagues from Saudi Arabia and New Zealand, okay, along with some colleagues from India too. Okay. We did a narrative review with a focus on anatomical features in individuals with Down syndrome. And here we did not perform any critical appraisal of the quality of studies. We just performed the narrative synthesis. The second type of narrative reviews could be editorials. Usually it's written by a journal editor or an invited guest. It may be a narrative review or no more than an editor's comments on a current issue or event. I tried to write a couple of editorials that have been published in the past few years, and we tried to explore different professional issues and commented on it. Commentaries may be written as narrative review. However, they're typically written with a particular opinion being expressed. I wrote a commentary in 2018 that was published in the International Journal of Osteopathic Medicine on the topic clinical versus radiological findings, which could be a paradox in diagnosing minor hamstring injuries. Here, I tried to express my opinion where there could be conflicting or contradicting paradoxical findings between clinical and radiological findings when you try to diagnose minor hamstring injuries. And I backed up with review of literature. And the crux of today's topic, systematic review and meta-analysis. A systematic review formally synthesizes and critically appraises the best existing evidence that answers specific research questions. The research questions should be specific when it comes to a systematic review. A meta-analysis is an extension of a systematic review where you utilize statistical methods to quantitatively evaluate pooled data from single studies. So you get an overall pooled estimates, okay? This gives more credibility to your findings when you have an overall quantitative estimate of the findings. I did my first systematic review in 2012. It was published in the journal Manual Therapy. I did it along with the supervision of my supervisors from New Zealand and Canada. Okay? Since I published that, there have been slight changes in the overall evidence synthesis guidelines. So that's a major change that I learned after that. A scoping review tends to address broader topics where many different study designs might be applicable. It is less likely to seek to address very specific research questions, nor consequently to assess the quality of included studies. So here, quality appraisal or critical appraisal of the risk or bias of the included studies is not usually done. It's usually an option. If somebody wants to do it, can do it. And it's an optional checklist item in PRISMA guidelines for extended scoping checklist. Scoping review is a form of knowledge synthesis that addresses an exploratory research question aimed at mapping key concepts, types of evidence, and gaps in research related to a defined area of field by systematically searching, selecting, and synthesizing existing knowledge. When you really do not know what is out in the literature, the study designs, or is there any evidence out for the topic that you're looking for, then you can opt to do a scoping review. I'm embarking on a scoping review recently, along with a couple of colleagues, one from New Zealand, the other from University of Queensland in Australia. And we are trying to do a scoping review on three-dimensional digital technologies as an educational tool in manual therapy education and clinical practice. It's still in progress, and we recently presented the preliminary findings in a conference in New Zealand. So the most important part of today's talk, steps involved in conducting a systematic review. Okay. The first and foremost step, you need to develop a rigorous study protocol that narrates the steps involved in conducting a systematic review. You must state the research question specifically, identify the eligibility criteria to select studies, detail a search strategy to identify all relevant literature, including published and unpublished evidence. Detail the study selection methods, detail the extraction of data, and establish a method to rate the quality or risk or bias of the included studies. Especially, this should be done at the outcome level. And this should be followed by strategies for evidence synthesis and providing an overall summary. The stage one, you must develop a rigorous protocol. You must narrate all the steps involved in performing a systematic review. And you have something called as PRISMA-P checklist, which stands for Preferred Reporting Items for Systematic Review and Meta-Analysis Protocols. It's published in 2015. And this checklist has the recommended items to address in a systematic review protocol. And you can register the protocol in a database registry called PROSPRO, which stands for International Prospect Register of Systematic Reviews. And here's the link for it. There's an alternate database or platform called International Platform of Registered Systematic Review and Meta-Analysis Protocols, inplasi.com, but this is a paid service, while the PROSPRO is a free one. But the problem is PROSPER takes time to register protocol. It takes few weeks to few months nowadays. Alternatively, you can register just the title of your review in JBI database, but they allow to register only those institutions that are affiliated with them. But they also have a journal called JBA Evidence Synthesis, where you can try to publish your protocol or your whole systematic review. They also publish scoping reviews and other types of reviews. Here's an example where we register our systematic review protocol in the PROSPER database, and simultaneously we publish in an open access journal, BMJ Open, which has a good impact factor. So you can register in the database at the same time. You can also publish your protocol, but only certain journals are publishing the protocols for systematic reviews. Stage 2 is developing the review question, most important part of a systematic review. And you can use PICO elements or strategy, where P stands for problem or patient or population, I stands for intervention, C for control, comparison or context of the review, and O stands for outcomes. So this is the most famous strategy for designing your research question. Here's an example. The aim of the systematic review is to evaluate the evidence for the effects of neuromuscular rehabilitation training on knee proprioception compared to comparator control interventions in persons with anterior cruciate ligament injury or reconstruction. So persons with anterior cruciate ligament injury or reconstruction refers to the population. Neuromuscular rehabilitation training refers to the intervention. Comparator control interventions refers to the comparators. And if you want, you can be even specific. For example, you can call strengthening exercise of the knee joint or conventional rehabilitation as the comparator intervention, or no intervention as the control intervention, if you want to be more specific. And knee proprioception refers to the outcomes, which could be in the form of joint position sense, threshold to detect passive motion, quadriceps force control, or something like that. And certain recommendations also ask us to include study design as part of the research question or the search strategy. Here, S stands for study design in the PICOs, and it can be also called a study type. The study designs include experimental studies or non-experimental observation studies. And here's a table summarizing different strategies that you could use. So PICO elements, PICOS elements, or SPIDER. Here, SPIDER stands for sample, phenomena of interest, design, evaluation, and research type. And SPIDER search strategy or elements have been recommended for designing a search strategy or review question for qualitative studies, where they have a qualitative outcome. So here, evaluation refers to qualitative outcomes. And there have been alternative terms or acronyms suggested. One is PIPO, where P stands for population, I for interventions, P for professionals, O for outcomes, and H for healthcare setting. And you can choose the best one that would suit the purpose of your systematic review. Identifying eligibility criteria of the studies to be included. The inclusion criteria should primarily address, amongst others, the following: participants, interventions, comparators, and outcomes. The same PICO for designing eligibility criteria of the studies to be included. In addition, if required, you can also include healthcare settings, professionals, construct to be measured. Here, in the example that I gave before, the construct measured is the knee proprioception. Equipment used, for example, they used a dynamometer or customized bespoke device or any other instrument that could be used for measuring different types of proprioception sensors. Depending on your research question, you can also add other items or domains for determining eligibility criteria of the studies to be included. This comes the challenging part, detailing the search strategy. You need to find appropriate keywords to retrieve all the relevant articles that could explore the search and get all the articles that are relevant for the eligibility criteria or you fitting the research question. So you need to find the keywords and you need to perform pilot search in a couple of databases at least to see whether the search strategy is working to retrieve all the articles. The search strategy is sensitive and specific enough to pick up the articles of interest. And after doing a pilot search strategy, you need to finalize the complete search strategy for retrieving articles from the electronic databases. You can also perform a hand search of relevant journals or reference list of the included articles to go for cross-referencing and to find relevant articles. After that, you can screen the titles abstracts and then end up with full text to include in the study following screening. You must maintain a record of all these search strategies. So whenever you perform a search in any database, okay, you need to add that in the history and save it. And also you create a alert so that it reminds you when new articles pop up in that search strategy. Okay. And depending on the electronic database search, the search terms will be mesh terms. Mesh stands for medical subject headings that applies to PubMed or Medline. Subject terms, subject headings, CINAHL headings for CINAHL, and M3 for Embase. And this could be in combination with keywords or text words. Boolean operators or and will be used to combine these search terms in all these databases. And also you can use limits. Example, you can include only English language studies. The period of search, for example, from the inception of databases to present day. And recent recommendations from JBI, they ask you to set no date limits when you're registering the protocol because you will not know when the search will be completed. And if you want to restrict to human studies and peer-reviewed studies, you can also have them as limiters. So you can also use the term not and include all these terms to exclude the studies that are not fitting this criteria list. Here is an example of search terms, and this is taken from JOS PT journal based on a study published by Nascimento et al. The most commonly recommended search strategy is based on PICO elements, where P stands for participants, I stands for intervention, C for comparator, and O for outcomes. And out of all the 4 elements, some of them restrict only to patient and intervention, just for the reason to explore the search to get as many articles as possible, and later then screen for comparators and outcomes. For example, if you're going to include too many terms in all the PICO elements, the problem is sometimes the search will be more specific, but becomes less sensitive. That means to say, it gets more relevant articles. At the same time, some articles might be relevant though, less relevant, but still it will try to exclude some of the articles that might be relevant for your systematic review. So that is most important. You should know that. Okay. So some of them just prefer patient and intervention and try to exclude comparators and outcomes. But most of the time, I would prefer to have patients, interventions, and outcomes, but exclude the comparators. It doesn't matter what else could be the comparator. If you're not so specific, you can search for it after retrieving the articles. One of the important things you should notice here, you can find an asterisk symbol at the end of searching certain terms. For example, femoropetal, followed by an asterisk. Retropetal, followed by an asterisk. Okay, so let us see what is that. So that is a truncation symbol. Okay? Truncation is represented by an asterisk. To use truncation, enter the root of a search term and replace the ending with an asterisk. For example, if you type adolescent followed by an asterisk, it will find the words adolescent, adolescents, all those relevant terms. On the contrary, wildcard is represented by a question mark. To use the wildcard, enter your search terms and replace each unknown character with a question mark. For example, if you type NE question mark for T, it will find all the citations containing need, nest, or next. At the same time, if you have confusion between British and American English, for example, analyze, you'll use Z in American English and S in British English. So if you want to replace those changing letters, you can also use a question mark. So that is called as wildcard. So truncation symbols and wildcards are commonly used as well in the search strategies. And don't forget that the truncation and wildcard symbols might differ from databases, but these are the common ones. One, for example, is the EBSCO. Here I have provided a couple of links. Simple subject search in PubMed and how to use mesh or medical subject heading to build a better PubMed query. Okay. Don't forget that the medical subject headings are used to index articles only in Medline and PubMed. Sometimes it becomes a tedious process. If you have more than 2,000 articles or 3,000 articles, you cannot manually copy all the reference and paste in a Word document and Excel sheet and screen it. It becomes more difficult. In such cases, use a reference management software program. And some of the examples include EndNote. It usually offers 1 month free trial. Mendeley, it's usually free up to a certain number of citations. And Zotero. These are some examples. I have been using EndNote for a long time, but it's a paid service though. Common databases searched include PubMed or Medline. The difference between PubMed and Medline is, in PubMed, you will be able to retrieve articles that are not yet indexed with the index or mesh terms. So you'll be able to find even articles that are in press. But the problem with Medline is you'll be able to find only those articles that have been indexed in the database. So I would usually refer to PubMed and recommend it. The other databases include AMED, CINAHL, Sport Discus, Web of Science, Scopus, Cochrane Central, Physical Education Index, PEDRO, OTSeeker, Embase. So these are some of them. There might be much more. So these are commonly used databases, at least for healthcare professionals. And you can see certain ones like EBSCO, ProQuest, Ovid SP. These are platforms rather than databases. So these platforms will have more than one database nested in them. And do not forget that database search should be done by at least one reviewer. If you want to have more, it's fine, but at least one person could do it. But it's better to have 2 persons if it's possible, just to prevent bias. Recent recommendations, especially those from the JBI, recommend us to include gray literature that includes unpublished evidence. Okay? Some of the databases include ProQuest Dissertations and Thesis Global, Medna, Trove, WorldCat, and there's some more. So these are some of the examples where you can try to retrieve theses and dissertations. And in order to be comprehensive, we should include both published and unpublished studies if possible, but it's more time consuming. And stage 5 is study selection. So once you perform this search strategy and retrieve articles from electronic databases and also perform manual hand search and other sources, and you retrieve all the citations, then you need to screen those citations for eligibility criteria. If they fit the eligibility criteria, then they should be included in the review. Okay? So once the studies are screened by 2 reviewers, then you need to perform data extraction. And this should be again performed by 2 reviewers. If you want to minimize the work, one person can extract the data while the other person can verify the data of the included studies. Some of the data to be extracted include study details, that is those of the citation, participant characteristics, including number of participants, age, gender, type of severity of injury or disease, times in onset of the disease, and eligibility criteria of the participants. Methods should include design, setting, participant recruitment and allocation criteria. If blinding of patients, assessors, or therapists delivering the interventions was done, time points when data were collected, if there was the loss of participants to follow up or dropouts for any reason, and recruitment and retention rates. These could be extracted as well. And interventions, the authors must have explicitly reported experimental and comparator control interventions, duration, frequency, intensity of the interventions, but the intervention was supervised. For example, those happening within the institution, or unsupervised home-based rehabilitation, and what were the assessment or measurement instruments used for assessing the outcomes. And especially when it comes to outcome measures, it's most important you must report which outcome measures are primary and which are secondary. And describe all the outcome measures. If possible, you need to justify whether those outcome measures are reliable and valid, and look for the units of measurement. And it's not your responsibility to look for the psychometric properties of the outcome measures. The authors must have reported it as part of their study. By looking at the results, look for intervention effects on the outcomes of interest. For example, mean change scores from the baseline, that is pre versus post intervention scores, mean between group differences, effect sizes, how big is the change or the effect of the intervention, adherence to the intervention age group, most important. Though the intervention could be delivered for any number of weeks, you should also look for adherence to the intervention by the participants in each group. And obviously look for conclusions of the study by the authors. And you can also review it and look for whether your conclusions based on the interpretation of the results are going to be different from those of the authors. But you need to perform a detailed analysis of the study for that, including risk of bias. There are data extraction templates published by Cochrane Group and JBI Group, and these could be customized for the purpose of your own review. Okay? And most of the journals will ask you to produce an appendix of the data extraction template, or at least the items used for data extraction as part of your manuscript. Ideally, you need to extract all data that would be required for summarizing study characteristics table and also for assessing risk of bias for each outcome of interest in the included studies, which would aid in a quantitative and/or narrative evidence synthesis. So extract data for producing summary tables of study characteristics and also for qualitative or quantitative evidence synthesis. But last but not least, you must have data for assessing risk of bias from each outcome of interest in the included studies. And next comes the challenging part, critical appraisal of the studies, okay, of the quantitative evidence. And again, this should be performed by a minimum of 2 reviewers, okay? To prevent bias, it should be done by a minimum of 2 reviewers to have consistency, to arrive at a consensus. If needed, if the 2 reviewers cannot agree, they must have 1 more reviewer at least to adjudicate and bring a consensus decision. Bias occurs when the results of a study do not represent the truth because of inherent methodological limitations in design or conduct of a study. There are several tools available to rate the risk of bias in individualized, randomized clinical trials and also observational studies. Here comes the hierarchy of quantitative study designs. On the top, you have the experimental studies that include randomized clinical trials, followed by quasi-experimental studies, which will also include controlled clinical trials, that is experimental studies without randomization, followed by controlled observational studies and case series, followed by expert opinion. And today I'm exclusively describing systematic review of only the experimental studies, and some of these would apply for quasi-experimental, for example, controlled clinical trials too. You can use many tools for assessing methodological quality or risk of bias of the outcomes of interest in each included study. For randomized clinical trials, you can use Cochrane risk of bias tool. And there's a new version. It is ROB2, risk of bias 2 tool, published in 2019. And you can also use Pedro scale. And the Cochrane risk of bias tool also has variations if you're going to include cluster randomized clinical trials or crossover randomized trials. If you want to look at risk of bias in non-randomized studies of interventions, then you can use Robbins 1, while Downs and Black checklist can be used for assessing risk of bias in both randomized and non-randomized studies. There are many more checklists. You can go through and find it in the literature. I will provide some light on the Cochrane risk of bias tool. Okay, so this is the one that is recently published, and I have used for a couple of reviews, and I will tell my experience based on that. Okay? This tool includes 5 domains: bias arising from the randomization process, bias due to deviations from the intended interventions. Here, what it means, sometimes the participants are allocated to each group, but after that, there might be deviations. Some participants might change from one group to the other for some reason. So these all might happen. So you need to look for bias associated with that. Bias due to missing outcome data. For example, some outcome data might be missing because of dropout of the patient, or there might be problems with the intervention. The patient didn't turn out for the follow-up, or sometimes there might be equipment or device failure so that they may not be able to measure the outcome. So these should be looked at as well. Bias in measurement of the outcome. It depends on whether it's going to be objective or subjective outcome, and whether they have reported blinding of the participants, the persons who are going to deliver the interventions, and outcome assessors. And there could be bias in selection of the reported result. For example, there could be so many outcome measures that the authors have registered in the trial protocol as such. What happens after they complete the study, they might report only certain outcome measures and they are not reporting everything else. Maybe because only certain outcome measures turn relevant. So that could be a possibility. Other could be multiple outcome measures for same construct. For example, if they're measuring pain, they can measure subjectively with visual analog scale, or they can use other ways of looking at it, physiological responses to pain, for example, or they could have looked at pain pressure threshold. Okay, so these are some of the outcome measures for pain. And they might end up in reporting only a couple of outcome measures that turn significant. There could be bias in reporting only those outcomes that turn significant for the sake of publication, okay, to increase the likelihood of getting published in a good journal. So this all happens. So you also look for bias in selection of the reported results. And this flow chart summarizes the process of assessing risk score bias in a systematic group of randomized clinical trials using version 2 of the Cochrane risk score bias tool that was published in 2019 by Stern et al. The most important thing you should notice is you need to pick up each outcome that is relevant of interest for your systematic review. For example, one study might have more than one outcome of interest that is relevant for your systematic review. And pick up each outcome from each study and look for risk or bias associated with that. The first one, specifying result being assessed. For example, you are looking at risk ratio or looking at mean change scores or mean difference between the groups. You need to mention that. And also you can refer to the table or figure where you're going to retrieve the data from. Then specify the effect of interest, whether you're going to look at intention to treat analysis or you're going to look at per protocol analysis. The intention to treat analysis refers to including all the patients or the participants in the intervention allocated to the groups initially, irrespective of the dropouts, whether they're going to retain and follow the study throughout and complete all the assessment, or they're going to drop out in between. It doesn't matter. You're going to include all the participants in the analysis, then it becomes intention to treat analysis. The other one is per protocol analysis. This includes only those participants in a particular intervention arm that they're going to complete the intervention. If there are going to be any dropouts, those dropout patients will be excluded from the analysis. But intention to treat analysis is claimed to be the best one to avoid bias. And list of sources of information used to inform the assessment. This is an important point. Where you go to retrieve the data from to perform this assessment. You can look at the published article. You can look at the appendices. If data are missing, you can contact the authors of the article to give the missing data to perform the assessment. And also if the trial protocol has been registered, you can also look at, okay, the protocol that's registered, is there any deviation from that? And each domain in the Cochrane risk score bias tool has certain signaling questions, and you have to answer all the questions. And each domain should be assessed for risk of bias. Followed by that, you can assess overall risk of bias based on all the 5 domains. I'll give some examples in the following slides. And for synthesis, integrate judgments into results and conclusion. Here they give an example, stratify meta-analysis by overall risk of bias judgment. For example, you have studies with high risk of bias and low risk of bias as well. You're trying to pool the data of both studies with high risk and low risk. That could be chances of getting an overall estimate. But you must know whether the results of the high risk studies are going to be different from the results of the low risk studies. In such case, you can perform a sub-meta-analysis or sensitivity analysis, and you can differentiate studies with high risk of bias and low risk of bias. This is called as sensitivity analysis. And this is not subgroup. Subgroup is going to be different. So this is called as sensitivity analysis. For example, if the studies with high risk of bias claim the difference between the groups and is telling one group of one intervention is better than the other, and if it's same with the studies with low risk of bias, then it's acceptable. Okay, and or else you need to perform a sensitivity analysis to look at the disparity between these 2 groups of risk of bias scores. And you can use a Prisma flow diagram to show the screening process of the articles. Records identified through database searching and other ways of that you recover the articles. And records after duplicates were removed, record screen, full text articles found to be eligible for inclusion in qualitative synthesis and quantitative. Here, quantitative synthesis refers to meta-analysis. Okay? And do not forget that you must explicitly state the reasons for exclusion of full text articles. That is most important. Okay, so as you assess risk of bias for the randomized clinical trials, there are tools to assess risk of bias in systematic reviews too. It is not like all systematic reviews are of good quality. So one of the major flaws they look for is not mentioning the reasons for exclusion of full text articles, okay? And if you have so many reasons and so many articles that were excluded following full text screening, you can also provide an appendix with reasons for exclusion of these studies. This is from one of the articles published by our team in Physical Therapy Reviews. And here comes an example of risk of bias table, okay, based on the 5 domains of the Cochrane risk of bias 2 tool. Okay. And you can see the included study citation on the left end in the first column. And then comes the outcome variable, followed by all the 5 domains of the risk of bias tool, followed by overall judgment at the end. See, what I want to highlight here, you can see that one article, for first 4 domains, it scored low risk of bias. But the last domain, it scored some concerns. Only 3 categories are recommended by the Cochrane tool. Okay, it could be low risk of bias, some concerns, or high risk of bias. So in this article by Fu et al., you can see that bias was found in selective reporting of the reported results. So it's got some concerns in one of the domains. Still, don't forget that even if one domain scores some concerns, then overall judgment will be some concerns. And even if the same for high risk of bias, even if one domain scores high risk of bias, then you should consider the article to be of high risk of bias. And don't forget that here we looked at outcome level. You can see JPS, TDPM, and QFC. And the article Shen et al. And Zult et al. Have been added twice. And this is because they had 2 outcomes of interest that were included in the review. Okay, both JPS and TDPM from Shen et al. And JPS and quadricep force control from Zult et al. Were assessed separately for risk of bias. So you should perform risk of bias assessment for each individual outcome of interest and not at the study as a whole, which was the difference from the earlier versions of other risk of bias tools. You can also give a graphical representation of percentage of studies showing low risk of bias, some concerns, and high risk of bias. Here, green refers to low risk, yellow, some concerns, and red, high risk. And on the top, you can see overall risk of bias. Around 55% of the studies had some concerns, and the remainder had high risk. And this is based on a systematic review, which is currently under review in a journal. Okay, so we tried to look at the evidence for the effects of neuromuscular rehabilitation training on knee proprioception in persons with anterior cruciate ligament injury or reconstruction. This has been done in collaboration with Umeå University in Sweden. And I'm going to give one more example of risk of bias table. And this is based on one of the systematic reviews published by my colleagues from India and New Zealand. And the review is titled Effectiveness of Physiotherapy Interventions on Disease-Specific and Generic Outcomes for Individuals with Cardiovascular Diseases in India. And here's an example of a risk of bias table. We can also present it as a figure. The green circles with plus refers to low risk of bias. Yellow circles with question mark refers to some concerns. And red circles with minus refers to high risk. And here you can see that the same study, Urvashi et al., has been added 4 times for 4 different outcome measures of interest from the same study that were included in the review. Okay? I just wanted to show a slight difference in the risk of bias assessment. You can see that for diastolic blood pressure, that is DP, the domain measurement of the outcome, it had a plus with the green color circle. That means that it is of low risk of bias. But the quality of like QOL, you can see it scored a minus for the measurement of the outcome. So it's from the same study, 2 different outcome measures had 2 different ratings. But irrespective of these scores, they all had some high risk for some domains, and overall risk of bias was scored to be high risk for those outcome measures. So do not forget that there might be difference in the risk of bias associated with outcomes from the same study. So that's what I want to mean. And diastolic blood pressure is an objective outcome measure, while quality of life is a subjective outcome measure. That also makes a difference. And the way it was measured and reported was giving a different rating for these outcomes. And most important, strategies for evidence synthesis and providing a summary for the whole review. Please perform a meta-analysis if possible or required. Whenever you have a minimum of 2 studies with adequate homogeneity of participants, interventions, and outcome measures, you'll be able to do a meta-analysis. You can perform a qualitative narrative synthesis based on the same strategy or elements that you used before, PICO, PICOS, or SPIDER, whatever is that. And you summarize the results for participants in the included studies, interventions used, comparators, and also the outcomes measured. And when it comes to study findings, try to report mean differences and effect sizes whenever possible to get an idea of how large the effect was for the interventions. And last but not least, do not forget, okay? You should always interpret the numbers or the mean differences or the effect sizes along with the risk of bias. For example, a study claims that an intervention is effective, and maybe it even shows a large effect. There was a large difference following the intervention in the symptoms or in the outcome measures. But there could be a problem. It might have a high risk of bias. So you should understand how far the results are valid or reliable, okay, or trustworthy. So always look at the findings along with looking at the risk of bias scores of the particular outcomes of interest in the included studies, okay? So both should go hand in hand. In case if you're performing a meta-analysis, the most commonly used one is Remen 5 from the Cochrane group. It is free to use, and here's a link for you referring to that. Even there are some other resources which include MedCalc, meta-analysis, Meta for package, and even Stata can be used. And some of them are paid services, okay? They're not free to use. Remen 5 is a free one to use. And you want to know how to use it, you can go through the Cochrane collaboration guidelines. And here comes an example of a meta-analysis performed by me for one of the systematic reviews that I quoted earlier on. Effects of neuromuscular training on knee proprioception following anterior cruciate ligament injury. Okay, I will explain how to understand this. First, you list all the studies on the left-hand side. And if you want to specify the outcomes, there are slight variations in the outcome measures or the more than one outcome of interest that could be pulled from the same study. So you can see that same study has been repeated and with different terms, JPS1, JPS2, JPS15, 45. Those refers to different positions or different target angles. The JPS refers to joint position sets. I've highlighted in red for one study. Here you need to enter the mean change score from the baseline. Mean change score from the baseline refers to the difference between pre versus post intervention scores, and also include the standard deviation and number of participants in each group. The most important thing to notice here, the biggest dilemma comes when the authors don't report the change scores from the baseline. Most of the time, it is the case that they give the pre and post intervention scores and standard deviation. But the problem is you'll be able to calculate the mean change score based on the pre and post intervention scores, but it's difficult to calculate the standard deviation. So the standard deviation cannot be accurately calculated. So that's a problem. So in such cases, what you can do, you can prefer to use post intervention scores for both the intervention group and the comparator group, provided that there are no baseline differences between prognostic indicators of both the groups. Okay, so as long as the groups are same at the baseline for prognostic indicators, then you might prefer to use post-interventions group for both the groups. So this is one option. The one more dilemma comes when some studies have given change scores and some studies have given post-intervention scores. It's better to be better to be consistent. You can use either post-intervention scores for all the studies, but if you're going to mix both of them, then make it sure that you mention it under the forest plot. The figure that is on the right-hand side is called as forest plot that comes from a meta-analysis. So once you provide mean and standard deviation values and number of participants in each group, it calculates mean difference between the groups and gives a plot. Okay? And one highlighted is having a wider confidence interval. If a study is giving a wider confidence interval for a particular outcome, it means to say that it is imprecise. It's not narrow. Okay, the values can fall anywhere between the range. Okay, so that's again a problem. And you can also see that they get less weightage in the meta-analysis. For example, this study had only 2.8% or 100% in the meta-analysis. Most important thing, see the diamond at the bottom of the figure, whether it falls towards the experimental group side or the control group side. If it falls on one side, it clearly favors that group. But what happens if it's going to cross the mid-zero line? It means to say that it is not favoring either group. So there is no significant difference between the groups. That's what it means out of the meta-analysis that we had here. One important aspect that you should look for is statistical heterogeneity, which could be assessed with statistics such as chi-square or I-squared. Here, I-squared has a value of 67%. A threshold of 40% is considered to imply statistical heterogeneity. If you have substantial heterogeneity, for example, 80 to 90% or even more, you can decide to exclude that meta-analysis and just perform a qualitative analysis. That is even possible. And these values refer to statistical heterogeneity, I-squared and chi-squared. The most commonly I used one is I-squared. And see that I have highlighted mean difference on the top of the forest plot. Why I'm telling this? If all the studies have reported the outcome measure with same units of measurement, then you use mean differences. If a study has reported one unit of measurement, while some other study has reported some other unit of measurement for the same outcome measure. If different studies are going to use different units of measurement for the same outcome measure, then you must use standardized mean differences and not mean differences. There's a way to calculate it. And if you use RevMan, it's easy to understand that. Okay. So in case if different outcome measures or the same outcome measures with different units of measurement, then go for standardized mean differences. Still, you'll be able to find a mean difference and look at effect sizes. Okay. And you can see the Baltasi et al. In the beginning of the forest plot, the first two ones, I've written as not estimable. The problem was they used a different unit of measurement. So what I decided, I decided to exclude them from the meta-analysis and include the rest of them with the same units of measurement. That's for Anglo error in degrees. And I created a mean difference plot. But if I had to include the other one, I should have used a standardized mean difference, which had a different unit of measurement. The next comes mean difference. You can see below I've written random. What I did, I used a random effects model, which means that the effect size varies from study to study. It's not the same for all the studies. On the contrary, if you're going to use fixed effect model, it is going to assume that only one true effect size underlies all the studies in the analysis, and the differences observed in the effects are due to sampling error. But that is not going to be the case. So most of the time, you might end up in using a random effects model while doing a meta-analysis, which assumes that the effect size varies between study to study. Okay. So evidence synthesis continued. Okay. In order to provide overall level of evidence in the review, you must use something called as grade based on recent recommendations. The grade stands for grading of recommendations, assessment, development, and evaluation. The grade approach uses a strategy to rate the body of evidence at the outcome level rather than study level. Don't forget again. Same like risk or bias assessment with the Cochrane tool. The grade tool also assesses the level or certainty of evidence at the outcome measure level rather than the study level. If the same study has more than one or two outcomes of interest, and you need to assess the level or certainty of evidence for each outcome of interest. Okay? And you can generate a grade table using a software called Grade Pro software. And here's a link for it. You can access it and try to generate a grade table. important domains that you need to consider while performing a grade assessment, or the assessment that you should do to determine the level of evidence. The 5 domains include risk of bias, inconsistency, indirectness, imprecision, and publication bias. So here, risk of bias might arise due to inherent limitations in the design or conduct of a study. And inconsistency might arise if several studies report or show inconsistent effects. And while looking at inconsistency, you must inspect the similarity of point estimate, that is effect sizes, and also the overlap of confidence intervals, as well as statistical criteria of heterogeneity that I talked about. An example is I-square. When it comes to indirectness of findings, if the patient studied are different from those for whom the recommendation applies. For example, if you're looking at an intervention for individuals with knee osteoarthritis, and you cannot extrapolate and generalize the findings to patients with problems of knee following rheumatoid arthritis. Okay, so you should understand that concept. If the patient studied are different from those who for the recommendation applies. The intervention studies are different from the real outcomes. For example, if you're using sophisticated equipment or devices to deliver intervention, but you're trying to generalize that to local clinics and community-based settings, it's not going to work. So I hope you understand that. So the external validity or generalization of the findings becomes difficult when you try to do with a lot of restrictions, sophistications with different equipment in a sophisticated hospital. Okay? Next comes imprecision. Look at the 95% confidence interval around the best estimate of the absolute effect. Here they're trying to refer to absolute effect and not relative effect. See, absolute effect is something they're going to look at the difference between the groups and trying to look at the mean difference in the same units of measurement of the outcome measure. And relative effect, what people do, they try to tell in a percentage. Okay, so this group improved by so and so percentage compared to the other group. But it's again, it is going to be an extrapolation and not the real effect. So always look at the absolute effect and best estimate of the absolute effect and look for 95% confidence intervals around the best effect. Again, if the confidence intervals are going to be very wide, as I showed in the forest plot, then again, you should know that it's imprecise. The confidence interval should be narrow. And if the effect estimate comes from only 1 or 2 small studies, you looked at the intervention and for specific outcome measure of interest, only 1 or 2 studies have reported with a low sample size. Again, it's imprecise. You cannot rely on it. Sometimes the outcome study is a surrogate for a different outcome that is more important to the patients. For example, if you're going to study fractures, and some authors could have used bone mineral density rather than looking at the outcome measures directly related to assessing a fracture. For example, looking at a CT scan and X-ray. So then bone mineral density measure becomes a surrogate measure. Okay, so you should take into consideration those points as well. Last but not least, publication bias comes into other considerations. It's quite difficult to assess this. It requires making inferences about missing evidence. And there are statistical and visual methods to detect publication bias. Some examples include trim and fill analysis, funnel plots, and so on and so. And sometimes it is impossible to collect all the evidence sometimes, because you might end up in looking at only the English language articles for some reason. You may not have the resources to translate the articles from different languages. That becomes a problem. And also sometimes you may not be able to look at all the unpublished evidence. For example, you will not be able to look at all the theses and dissertations published throughout the world, but you try your best to collect as much as possible based on the repositories that are available. Okay? This is one of the domains, okay, which needs consideration as well. So it comes under other considerations. Okay? And the evidence can be less certain or more certain as well. And there's a criteria for it. And here is an example for grade table certainty assessment. Okay? And this grade table is from one of my systematic reviews that looked at the effects of neuromuscular training on knee proprioception following anterior cruciate ligament injury or reconstruction. Okay? We found 3 outcome measures of interest knee joint position sense, knee joint threshold to detect passive motion, and quadriceps force control. Okay, that is force sense. Okay? And out of 9 randomized clinical trials that were included, okay, 7 of them looked at knee joint position sense, 3 of them looked at threshold to detect passive motion, and 1 looked at quadriceps force control. It is 7, 3, and 1, but don't calculate it as 10 because a couple of studies looked at more than 1 outcome measure. All the domains of grade have been highlighted in yellow. What we found was we had serious concerns with more than 3 domains, that's grade domains, which led to very low certainty of evidence. Okay? And this means to say the confidence with which we can say one of the neuromuscular training programs that we reviewed could be employed for improving knee proprioception following anterior cruciate ligament injury or reconstruction. And I have provided reasons for each domain, why it was serious. Here's another example of grade certainty assessment table. This from one of the other systematic reviews that I did with the Swedish group. We looked at the effects of robotic assisted grade training on objective biomechanical measures of gait in persons post-stroke. And one only difference I wanted to show here, we did a meta-analysis in this systematic review. So we were able to add effect sizes in the same table for each outcome measure. You can see absolute effect sizes with 95% confidence intervals. But we prefer to use standardized mean differences, that is SMD, because the units of measurement for each outcome were different between the studies. And whenever you have a meta-analysis and absolute effect sizes, you can easily find out the magnitude of the effect, the direction of the effect, how wide the confidence intervals are, and overall effect estimate favors an intervention or not. So if you have meta-analysis, it becomes much more easy, but it's not always possible due to so many other reasons because of clinical heterogeneity or statistical heterogeneity and so on and so forth. So if you have meta-analysis, you must also include effect estimates as a part of the grade certainty assessment. And here you can see I have highlighted all the 5 domains of the grade. And we found that more than 2 domains had serious concerns. Again, it resulted in very low certainty of evidence. Okay, the definition of quality levels based on grades, evidence synthesis. Okay, so if you say high, you're confident that, very confident that the true effect lies close to that effect estimate. So the one that you found in a review, you calculate effect estimate based on the comparison of interventions. That effect size, you're quite confident the true effect is within that, within the confidence interval of the effect estimate. What is moderate? You're moderately confident in the effect estimate. The true effect is likely to be close to the effect estimate, but still there is a possibility it could be different. If the quality is low or the certainty of evidence is low, it means to say that your confidence in the effect estimate is limited. There are chances that true effect may be substantially different from the effect estimate that you found. Very low certainty of evidence or quality that we saw in the previous 2 examples. What means that to say that? What it means is that we have very little confidence in the effect estimate. That is, the true effect is likely to be substantially different from the effect estimate that you found. So it means to say that you must do more research to confirm the research question that you have in hand. If you find high certainty of evidence, you can quite be confident that the further research is not going to alter the effect estimate or alter the findings to answer the research question. And you can find a series of grade articles published in the Journal of Clinical Epidemiology by the grade group. If you want to know in detail, please go through them. There's another rating criteria that was used by me in the systematic review that I performed first in 2012. And this criteria list includes only 2 domains of the grade. For example, consistency of the findings and methodological quality of risk of bias. I'm not going to talk in detail much about this because this is not used much now. The recent recommendation is to use grade criteria for looking at the certainty in the review, okay, certainty of evidence in the review. So other factors to be considered while performing a systematic review. If somebody asks for ethical approval, just tell them it's not required for a literature review. People understand that. And if you have funding for doing a systematic review. For example, if you're looking at an intervention that was delivered using a device marketed by a certain company that is going to sponsor you for the research, and you must tell the role of funding sources. That's for funding sources, actually. And you must tell them they do not contribute to any aspect of the study design in order to avoid conflicts of interest. They contributed somehow in the design and other steps of the systematic review, then you should mention another conflict of interest. Role of contributors here, you should mention all the people who took part in the conception, design, and execution of the review, and also writing the manuscript and submitting it. So authorship will be based on the contributorship, what they actually contributed for the review. And if you want to know further about the eligibility for being an author, there are certain portals you can go and look for. Okay, International Committee for Medical Journal Editors is one of the portal you can go and look for. Okay? Conflict of interest, I discussed a bit before. If funding sources were involved, or if you were involved or taking money for performing this review for some reason from a funding source, or whatever is that, you must be able to declare that. Okay. I have been talking about assessing risk or bias in the outcomes of interest for particular systematic review based on the included studies. And it's even possible to assess the quality of a systematic review. It doesn't mean that if you perform a systematic review, it's always of high quality. Even systematic reviews can be of low quality and high quality. Okay, some of them could be critically flawed, or the confidence in the systematic review could be critically low. So to determine that, there is a measurement tool called as Asst.2, which can be used for critical appraisal for systematic reviews that include both randomized and non-randomized studies of healthcare interventions. And this tool demands prior registration of the protocol of a systematic review before embarking on the systematic review. And if somebody is missing a protocol registration for a systematic review before commencing the review, it is considered as a critical flaw according to the Asst.2 tool. And the Asst.2 tool also asks for description of the role of funders in the included studies. Okay, and this is also assessed as part of the critical appraisal. And these are not commonly reported in the systematic reviews. And registering a protocol is always a debate. For example, if you're going to give it to Prosper, it is going to take a few weeks or even more. And they don't register scoping reviews, for example. And there are some other, if you don't have clinical outcomes, for example, they have some criteria, okay? So you cannot register all the systematic reviews with them. Again, that becomes a problem. And not all the high quality journals ask for registration of the systematic review protocols, and they accept even without pre-registered protocol. Okay, I've seen in JAWS PD, Musculoskeletal Science and Practice, and even some good journals where they publish systematic reviews recently, even without a pre-registered protocol, due to so many authentic reasons. And it is recommended to have a pre-registered protocol. It's always well and good. And there is a possibility for getting it published even without a pre-registered protocol. Nevertheless, you must have your protocol designed before embarking on a systematic review. So I told some examples for reference management softwares like EndNote, Mendeley, and Zotero. Okay. Those are just reference management softwares, but there are some web-based programs or applications for managing data of systematic reviews as such. A couple of examples here, Covidence and Ryan. I've used Covidence much, and some of my colleagues are using Ryan. And Ryan is free while Covidence is paid. And you can perform all the steps of systematic review with Covidence, from retrieving the articles and exporting to Covidence, from the onward screening of the articles by 2 or 3 independent reviewers. You can have individual login and do it separately. You can use the app with the mobile, and you can do it even during a leisure time. So there's so many ways to do it, okay? But it's a time-consuming process. That's what I want to remind. If you want to publish your protocol, there are only few journals that publish systematic review protocols. Some of them include Physical Therapy Reviews, JB Evidence Synthesis, Journal of Advanced Nursing, BMJ Open, Systematic Reviews, and these last 2 ones are open access and paid ones. You might have other journals you need to look at. conflicts of interest, none declared. I would like to express that I do not belong to the Cochrane group, the JBA group, or even the grade group. And the views expressed or explicitly of mine based on my research and learning experience, and they do not belong to the position statement of my university or my collaborators. And there might be some disparity in what I quoted today. Please go and refer to appropriate sources like Cochrane, Grade, or JBA Group to know more about it. And they are based on my experience, what I learned, I told you today. And here are some references. And I quoted only the important ones. And I would like to thank all the collaborators from different universities. Some of them include Ymir University, University of Otago, Aura Institute of Canterbury, and some other universities from India, Australia, and US too, who have taught me so much regarding systematic reviews. Last but not least, I would like to thank all of you for patiently listening to my talk. If you have any questions, please ask me. I would also like to thank Dr. Chandramohan and his team for giving me this opportunity. And it's open for questions if there are any.
Thank you so much, Dr. Ashokan Arumugam. And there are a few questions, and there is a question from YouTube.
Yes, please.
Just posting here from Binoy Matthew. Will this cause confusion to reader if we are using Cochrane risk of bias to tool denoting some concern and high concern if bias is only on one subset?
Can you repeat the question? It's not so clear.
Will it cause confusion to readers if we are using Cochrane risk of bias tool denoting some concern and high concern if bias is only on one subset?
See, there's no confusion in that. You're going to assess risk of bias at each outcome level, and you're going to look at the level of evidence for the particular outcome measure in the grade 2. So one outcome measure is having low risk of bias, and one has high risk of bias. While you're going to take into the grade evidence synthesis, it is going to be assessed separately. It's not going to be a cause confusion to the readers. That's the best way to do, I'm telling you. Hope it is clear. Okay.
I hope so.
If you have more questions, they can ask them actually.
Yeah, the person Binay Matthew is watching through YouTube. He's not in Zoom, but hope he will be convinced. In case if he needs any clarification, I will give you a number or
yeah, I can give my email ID.
Again.
That's not a problem.
Yeah.
Thank you.
And one more question from Zoom meeting. Sir, those from Dr. Kalpana Jutsi from New Delhi. So those students who are novice in systematic review and meta-analysis, what are your basic suggestions for them?
Okay, there are YouTube videos, and also there are videos from different university websites where they clearly explain the steps in systematic reviews. Even if you go through Cochrane Group, and even if you go through JBA Group, they have elaborate explanation of all the steps that are needed for a systematic review. My sincere suggestion would be to go through those videos first, then read the text. It's always easy to look at visually, followed by reading the text becomes much more easier. And there are some articles that describe how to perform a systematic review. All the steps that I described today, they are given in different articles. If you want those references, I can pass on them. But watch tutorials before doing it. It's much more easy to do. So that's my sincere suggestion. Actually, if you want some articles that summarizes all the steps in the systematic review, I'd be happy to do so. Just send an email to me. And also I can send you the links of the tutorials from different universities.
Yes, Kalpana Jutsi madam, hope you're clarified. Yes, I will give Sar's email ID to you, madam. No need to worry about it. Yes, we can post if he sends any tutorial links. I will post it in the WhatsApp group. Yes, thank you so much, Jitendra sir, and many have thanked
My pleasure.
you Yes, sir. And I think almost we have participants from around 10 countries, from Saudi, Dubai, UAE countries, and Australia, UK, USA, and from Pakistan, Bangladesh, so many countries. Today we have, it was really wonderful. And we had more than 400 registrations, 450 around. And many were watching in our YouTube channel, Fitness and Rehab India. Those who are having any doubts, or those who are watching in YouTube channel, kindly you can post your questions. We will read it here. Dear participants in Zoom meeting, if you have any queries, please ask our resource person. We'll take 1 or 2 minutes more to wind up. Any queries? We can see a lot of
Sir, there
professors
is
here today.
another question in YouTube. Please check.
Yes, madam.
Chandramohan sir,
Yes, madam, please.
there is another question in YouTube. Kindly check.
Madam, I couldn't get it. Do you see it?
I will be forwarding here, sir.
Yeah, kindly forward it, madam. I think, is that from Binoy Matthew?
No, sir. Vikas.
Okay, madam. I couldn't see it. Kindly post that one in chat box, please.
Sir, I have forwarded here in
Yes.
to you in chat
From
box.
Vikash, sir, how to retire a study for the review, which has not done in our topic or outcome we want to do earlier, but done with other outcome measures. I think he is asking, sir, how to rewrite a study for the review, which has not done in our topic or outcome we want to do earlier, but done with other outcome measures.
You can do a scoping review, okay? Before embarking on a systematic review, not so clear of the outcome measures, what is out in the literature, and if you are not sure about the study designs, for example, or you really don't know whether you have articles published in that area, then you can try to do a scoping review as a starting point, as I told you, where you need not do a critical appraisal of the quality of the studies, you can just perform a review with any number of study designs included, and risk of assessment is not needed. And scoping review is the best option to start with before embarking on a systematic review in such a case. And if you want to know more about scoping reviews, there are some guidelines. If you want some references, just write an email to me. I'd be able to help you. Okay.
Okay, thank you so much, sir. And there is a question from one among our senior professor from Chennai, Dr. T. Sandal Kumar. His question is, how the relevance of screened articles could be derived?
Based on the eligibility criteria. You must have your eligibility criteria specified before embarking on search. So you can use any of those elements, PICO, spider, whatever is relevant for you. And clearly, explicitly derive all the requisites or prerequisites for choosing an article. So that would help you to, and it should be done by minimum of 2 reviews, as I told you before. So avoid missing any article and also to come to consensus. Thank you.
Okay, so the next question, hope Dr. Sandal Kumar sir is convinced. And the next question is from, his name is Wind, from YouTube viewers, I think. Hi, in some of the reviews, forest plot favors experimental group, but author implies that low evidence to support experimental group. How could that happen?
That's what I told you. Okay. So, for example, if you're doing a meta-analysis, you might intend to include all the studies irrespective of the risk of bias. So that's how it starts. You can include all the studies first, irrespective of the risk of bias scores, those with high risk, some concerns, or low risk, for example. But you need to perform a sensitivity analysis followed by that. So sensitivity analysis separates those with high risk and low risk, for example. And if there's a discrepancy or disparate findings compared to studies with high risk and low risk, then you might end up in concluding that. So still there is very low certainty of evidence. And the certainty of evidence doesn't come only based on the effect size estimates. As I told you before, you need to look at risk or bias of the studies, inconsistency, indirectness of evidence, imprecision, and also look for other considerations like publication bias. So that determines whether the evidence is high or low.
Okay. The next question is from Sneha. Sir, could you please explain what is effect of measures? It is one of the questions from Prospero.
So tell again.
Can I read it again?
Read it again, please. Again.
Sir, could you please explain what is effect of measures? It is one of the questions from Prospero. Prospero.
Effect of measures. Okay, measures of.
Yeah.
I need to look at the Prospero protocol if you want to look at it. Actually, there are certain questions, certain items have been described differently for them. Effects of measures. Obviously, you need to look at how you're going to measure the effect of it. Actually, some of them, as I told you, mean change scores or effect sizes, and the effects of measures of intervention. And also, you need to think about when it comes to risk or bias. You need to look at it. It's going to be intention to treat analysis or per protocol analysis when it comes to clinical trials. Effects of measures. It could be also effects of outcome measures. And there's one component which also asks actually whether you need to mention whether you're going to look at the effects before and after, also during part of the, if they have interim follow-up. So that could be as part of it. But if you want more look at specifically at the domain, there's always explanation below that, what you need to fill in, you need to read that. It's not on the top of the mind. If you have some questions, you can write back to me. You can write an email to me.
Thank you so much. And Dr. Setil Kumar said thank you and for the informative session. And there are many appreciations for you.
I appreciate it.
And
it's just based on what I learned, and you need to go and read again to confirm what I told you. It's based on my learning and research experience all these days with different team members from different countries who taught me so much. And I learned something new from the reviewers every time. Still, I submit a systematic review. They bounce back with a lot of comments. And they tell me I'm not perfect all the time. So it's part of research. Criticism is always there. So take it constructively and keep going on. And I don't claim I'm an expert in systematic reviews. I'm still learning a lot every day. And I just shared my experience, what I learned all these days. And if you have some questions, write an email to me, or if you still have questions, I can stay for some more time. It's up to you guys.
Duna madam, can you please check once in YouTube if there is any question?
Only appreciations, sir. No more questions there.
Yeah, a lot of appreciations in YouTube also. There were more than 60 plus viewers in YouTube watching it live now. And to all the viewers and Zoom meeting participants, after 10 minutes of closure of this session, we will be sending you link through WhatsApp. In that, go through that link, you have to answer all the 5 MCQs asked correctly. Automatically, it opens the certificate. If you don't answer all the 5 correctly, you cannot download. You can retry. You can retry. Okay, that link will be open for next 30 minutes only. Okay,
the questions are quite easy.
Yeah, quite easy.
I just made it so simple. Don't worry. I should be able to answer it.
Yes. That is one or other way it is good, so that we will come to know that whether it is really worth for them, whether they really attended to gain knowledge or just to take the certificate only they have registered. So it is best, let them answer, at least by answering them, let them think that what is the question is and what would be the answer. So anyway, the session is for to learn only. That's why we made it. Though it is free, we want to provide a better quality of education. That's why we made it. Yeah. I thank all the participants for your time, wonderful time. And I take opportunity to thank once again Dr. Badri Narayanan, cardiologist, and Dr. Ashokan Arumugam. From the very fast till the end, he didn't lose the energy. It was like he kept on going till the end.
Hope it was understandable. Hope they understood something. I don't know.
Yeah.
I appreciate
pro-
it. Hope I wasn't too fast. I don't know.
And thanks all the participants from many countries and from most of the states from India. And I thank my EXRX India team members, Dr. Rupesh and uh, Professor Duna, for their continuous support. And I thank all the professors who have attended and all the students. Hope this session was helpful to you all. And thank you once again. And Ashokan sir, you can thank the participants so that we can wind up.
Okay, I would like to thank all the participants for attending the session and listening to me patiently all this time. If you have some questions, you can write an email to me. If you don't get a reply immediately, please hold on, send a reminder after a week. I'll be able to reply. Last but not least, I would like to thank the organizers, Dr. Chandramohan, Dr. Rupesh, and Professor Duna for this wonderful opportunity. I would also like to thank my brother, Dr. Badri, for recommending this. Okay? And thank you once again. And if you want my email, you can get it from them. I've written it there in the chat as well. And all the best. Hope you will be able to do good systematic reviews in the near future. Thank you for this opportunity again. Nice talking to all of you. Bye.
Thank you all. Thank you, Ashokan sir.
My
Thank you
pleasure.
all. Good night. Bye bye.
Bye. Thank you. Bye.